intracranial hemorrhage. We will start from germinal matrix hemorrhage. Before we start, we have 5 main questions. What is the germinal matrix? What is its importance? Where is it located? It is transient or permanent? And why germinal matrix hemorrhage is the commonest intracranial hemorrhage? What is the germinal matrix? It is a fragile thin-walled vessels and migrating neuronal components. It is formed early during embryogenesis, and it is the site of glial and neuronal differentiation from which the cells migrate peripherally to form the brain. And it is transient, involute by 34 weeks, and start to regression from 24 weeks. After that, the remnants remain in the thalamocaudate notch and in the temporal horns. Where is it located? It is located within the periventricular region and in the ganglionic eminence, and most pronounced in the caudate nucleus. This is the ganglionic eminence, and this is the caudate nucleus. This is the caudate nucleus. Okay. Why it is the most common intracranial hemorrhage in neonate? Because it is highly vascular, highly metabolic, and highly cellular. So any affection on any hypoxia or ischemia will cause hemorrhage. And it is highly vascular. This vasculature is fragile because the blood-brain barrier, as the germinal matrix, is distinct because due to lack of pericytes, which lack of coverage. This is the pericyte, and lack of fibronectin within the basal lamina of the basement membrane, and the lack of glial fibrillary acidic protein, which is secreted from the astrocyte in the feet. This is the astrocyte in the feet. This is the pericyte. This is the basement membrane. So it is fragile. So any neonatal stress, any perinatal stress, plus for cerebral tribulation equal hemorrhage. What is the risk factors? We have 2 intrinsic factors, low birth weight and cyanotic congenital heart disease, and 2 extrinsic factors, prolonged labor and multifetal pregnancy. As we said, any perinatal stress plus poor cerebral autoregulation equal hemorrhage. Let's start. Germinal matrix hemorrhage, known as periventricular intraventricular hemorrhage, and it is the commonest type of intracranial hemorrhage in neonates, and usually occur within the first week of life, and may cause significant morbidity and mortality in this population. 90% of germinal matrix hemorrhage are identified within 4 days of birth, and 40% within the first 5 hours. The more the prematurity, the more the hemorrhage. 80% of infants born between 23 and 24 weeks develop germinal matrix hemorrhage, and 67% of infants born between 28 to 32 develop germinal matrix hemorrhage. Clinical presentation, grade 1 and grade 2, usually asymptomatic and found on routine ultrasound. Grade 3 and grade 4 usually come with respiratory stress, abnormal posturing, seizure, and maybe bulging of the fontanelles. Grade of the germinal matrix, we have 4 grades, grade 1, grade 2, grade 3, grade 4. We will start from grade 1. It is limited to subependymal region within the caudothalamic group, overall good prognosis and 3.1 mortality. This is normal. This is the caudate nucleus. This is the thalamus, and this is the coron plexus. You can find echogenic lesion anterior to the caudothalamic group, and we have bilateral grade 1 germinal matrix hemorrhage. Grade 2, it extends into the normal sized ventricles, filling less than 50% of the volume of the ventricles, overall good prognosis, and 7.8 mortality. This is the hemorrhage. This is the hemorrhage extend into the normal sized ventricles. Grade 3, extensive hemorrhage with ventricular dilatation, and 21.3 mortality. This marked ventricular dilatation with hemorrhage. This is the hemorrhage. Okay, grade 4, any parenchymal involvement in the previously mentioned 3 grades, it is called grade 4, and it is caused due to conversion of the outflow of the veins by the subependymal hemorrhage. And it's called the periventricular hemorrhagic infarction. Any parenchymal involvement is called the periventricular hemorrhagic infarction. This is periventricular hemorrhagic infarction, and this is the frontal horn. It's completely filled by blood. We have grade 4 on the left side and grade 2 on the right side. By CT, any hyperdense region keeping with hemorrhage. And in grade 4, we may have found low density areas which represent venous infarction and hyperdense areas which represent hemorrhage. This is a case of CT brain, non-contrast CT brain. We have periventricular hemorrhage and the marked dilation of the ventricular system, and we have CSF blood level. So we have grade 3 germinal matrix hemorrhage. By MRI, it depends on the age of the bleed, maybe hyperacute, acute, early subacute, maybe late or chronic. Here we have a case of we have marked dilation of the ventricular system, and we have altered MRI signal seen within the lateral ventricle, extending to the coronary plexus, displaying bright signal fill T1, and low intensity REM fill T2, and high signal fill flare with restricted diffusion. So we have grade 3 germinal matrix hemorrhage with early subacute blood. Complication of germinal matrix hemorrhage, post-hemorrhagic hydrocephalus, periventricular leukomalacia, cyst formation. First, post-hemorrhagic hydrocephalus, periventricular leukomalacia, subependymal germinating cyst, and unilateral polycephalic cyst. What is the treatment? The ideal treatment is the prevention of premature delivery. If it is a must, you have to give dexamethasone for the mother or indomethacin to the infant, and you have to treat the complication. If there is hydrocephalus, you have to do CSF drainage.